Hi, I'm Tammy Potter, and welcome to the Pregnancy Process Podcast, a show designed to help you navigate the hugely transformative journey to motherhood, where you'll hear the unique experience of experts in this area and the incredible stories of women sharing their conception, pregnancy, and postnatal journeys so that you can have a healthier, more informed pregnancy. In today's episode, I talk to Lidia Molinara, founder of Moms Healthcare Navigator, UN Women's Health Advocate, pharmacist, and patient safety officer. If you're frustrated by how often women's pain and hormonal health concerns are dismissed as just part of being a woman, you're not alone, which is why in this episode, Lidia and I uncover why women are still left to shoulder the burden of contraception and navigate hormonal health in a system built on outdated research and persistent gender gaps. Lidia draws on over 30 years' experience to share real stories, practical strategies, and her ACE framework so you can advocate for yourself and your family, communicate confidently with healthcare providers, and make informed choices at every stage, from adolescence through to menopause. Whether you're a mum, a patient, or someone who cares about women's health, this episode will empower you to demand better, more equitable care. Lidia, thank you so much for your time today. It's fantastic to have you here with us. Lidia, thank you so much for your time today. It's fantastic to have you here with us.
Oh, thank you so much. I appreciate being able to spread some more information and have the platform in order to do that.
I'm really excited to have this conversation, and I think let's just start this conversation framing the hormonal lifespan, if that's okay with you, because you've described women's health as a lifelong hormonal journey. And if we take contraception as a central thread in this tapestry, how do you feel this exposes the systemic gaps in healthcare and research when it comes to women?
We started with contraception in the 1960s with the birth control pill, and there was, like anything, there's research done with the drug companies, and then you have go to market, and then we have evidence-based practice, and we see how things go. I think the critical thing is that women's contraception, as much as we say it's progressed, we're still dealing with basically two hormones, estrogen and progesterone. We are not necessarily really understanding what the long-term consequences of using these medications are. We've done some research on that. We've done some retroactive studies to see what happens, but it is a lifelong process. And now we see young girls, whether that's the change in our food systems and the hormones that are put in with the different food and agricultural systems, where now young girls are having their periods younger than before too. So you might have a 9 or 10-year-old having a period. And so now it's navigating that situation and how you control those emotions and what you're doing with that. There's girls that have 14, 15 severe acne, and instead of going on acne medications, we put them on the birth control pill as an alternative. So what are we saying then about the research with reproduction later when they're in their 25, 30, 35 years old and they want to have a baby, and then somehow there's consequences that now don't allow them to? Can we relate that to the birth control pill? A lot of those things, we have good information. I'm not saying we don't. It's been since the 1960s. Things have evolved, but we're still relying on women mainly to use methods and barriers for contraception. That is what we do. We have the burden on women. And I'm not sure that we shouldn't have done more research in male contraception throughout this entire time, because that would be fair. It's 50% of the burden is not just on the woman. But of course, since we bear the children, we ultimately have the responsibility of protecting our bodies too. So I think there's lots of research that still can come. Women's research is now, I think there's a movement to improve and increase it because you have a lot more women physicians, a lot more women researchers that are looking at things, that are trying to push for this information. We see that in the later stages with menopause and perimenopause. There's a big surge of information coming out. A lot of women researchers, women physicians looking at different methods to try and cope with the estrogen and progesterone levels that decline at that stage of life. So we're progressing. There's always going to be work to do. But the fortunate thing is, we are moving forward in some research. The science catches up. And it would be nice if we could, I think, understand more about what women go through when we're put on these medications. I think we don't have that system, even as a pharmacist. You come in, you pick up your birth control, I tell you a few things, you go home. I think there's more that needs to be discussed before someone goes on these medications. There needs to be really good screening and thoroughness. I think we take it for granted that these are medications we've used and we used them for a long time, so they're okay. And I don't know that safe mentality, that safe culture mentality is serving everyone appropriately.
And I would agree with that on so many levels. I haven't done a lot of research around this area, but I would hazard a guess that the research around female contraceptive probably hasn't changed that much since the 60s, even though research itself has progressed in leaps and bounds. But you've brought up a couple of interesting things and opened up that more adolescent and early healthcare engagement. So let's start there. Why is it that contraceptive care is often the only kind of healthcare interaction that's offered to adolescents? When symptoms like pelvic pain, you're looking at 4-5 year diagnostic delays. And a lot of times that pelvic pain is just being dismissed as, oh, it's just part of being a woman, or you're just not used to having cycles yet, and things like that. So you've got young girls that are having severe pelvic pain and their pain's just being dismissed. Yet, like you said, they might have cystic acne or something like that, and they're being put on contraceptive care. Why is this?
I think what happens is the science, as we discussed, a lot of research, women's health is not studied as much. And we know this across the board. There just isn't as much research. We're getting better, but it isn't there. So when we don't know something, it's very
Mm.
easy to dismiss it. So if, somebody's coming to the pharmacy and we have a rap sheet of side effects on a particular medication and someone's saying, "Yeah, but I have these massive headaches." And we look and say, "Oh, headaches aren't part of the side effect profile." It's not that we don't believe them, but it becomes almost dismissed because it's like, that doesn't make sense. It doesn't match. So I think what happens is, a lot of times when you're trying to explain what's going on with you, if there isn't a definitive diagnosis or something doesn't add up, sometimes it's unfortunately dismissed. And that's where you really have to advocate. That's where tracking, making sure that you track your cycle, track the pain levels, have a good idea of what makes it worse, what makes it better. Do certain foods like dairy make things worse or not? Trying to track things during that cycle and knowing the monthly, what that outlook looks like. It comes every 28 days, it comes every 35 days. Having that information, it somehow gives you that advocacy piece where you can then really go forward and say, "Look, I've tracked this. This is what's happening. This is my last 3 months. I have this and this." And when I was 19, I had so much pain when I had my periods that it would basically make me, I had to go home from work. Like, it was terrible. I'd curl up in a ball. I thought to myself, ibuprofen, whoever invented that was the best person in the world, because that was the only thing that got me to at least sit in a chair and eat dinner. And it turned out I had endometriosis. It took
Mm.
till I was about 24, 25 years old to figure that out. Right. So it's because period pain is so subjective. I have a lot of pain. You might not have any pain, but what is a normal amount of pain? And when you're speaking to a physician, unless you're saying my pain is 9 out of 10 for 4 days and I bleed and I pass through 5 tampons, that's the definitiveness where, because you can be so specific, that's how you get yourself to advocate in a better situation. And that's why I always say the three key principles in navigating healthcare is ACE. You have to advocate, You got to track and communicate, and you got to educate yourself. Had I had, like way back when, had I had an internet and I could Google some signs and symptoms of what I was going through, maybe endometriosis would have come up. Like now, today, that is something someone could do. So you can start to research and look at some things and see what pelvic pain could be and what other signs and symptoms do I have that match some of those diagnoses. And then you take that and you go to the physician with that information and you have a discussion. It doesn't mean you diagnose yourself, because there's a bunch of tests and ultrasounds and things that will help. But at least you can say, you know what, I really would like an ultrasound to find out why I have this pelvic pain. And then it grabs a different amount of attention. Or I would like to see a gynecologist and get this looked after and treated. Because unfortunately, not understanding most of the time equals dismissiveness.
It's incredible that, as we even mentioned, that you had a personal story around that. And even off the top of my head, I can think of one of my friends who's got a teenage daughter who suffers from quite severe pelvic pain throughout her cycle. And she doesn't quite know what to do about it either. So, this is for both parents of adolescents as well as adolescents themselves. That's really good advice, to make sure that you're tracking things and making note of them, so you can really go to a physician and be like, these are my signs and symptoms. This is what the pain feels like. This is what it's like on a month to month basis, and actually really give them some information to be able to start that diagnostic process, so you're not facing the dismissal and the delays. But in terms of lack of education around hormonal health, especially in that adolescent period, how does this almost set the stage for lifelong distrust in the healthcare system? And are there ways that we can go about changing this?
Absolutely. This is what I'm trying to educate on. Is the healthcare system is complicated. There's
Mm.
complexities in it. There is, you have to consider, if you are on the other side of the equation, someone comes in to see you, you have 15 minutes to talk to someone, to explain, to listen, to find out what's going on. And if the conversation isn't directed in a clear, concise manner, you as the physician might not hear or see what the urgency is either. So I see it as being a collaborative approach. You have 15 minutes, and in that time, as the patient, you need to be very clear and concise in what your concerns are. Pick three, ask your three main questions. Why do I have this kind of pain? What can we do about it? What tests should I get in order to figure out what's happening? And then you list, I have had 9 out of 10 pain. It happens every time my flow. I change 5 pads, I change 8 pads. I can't go to work. I'm like flat out in my bed, curled up in a ball, unless I take an anti inflammatory. What can I do? And I wish I would have known that back then. I
Mm.
wasn't a pharmacist at that time. I didn't understand the way the healthcare system worked. But had I had approached it that way, I would have been seen and heard in a different way. And I think the onus isn't just because the physician doesn't hear you. The physician could be male, could be female. It's not so much that, it's how you present what you're going through. And that's going to resonate in a different way. It's no different than when you're speaking. It's a collaborative relationship, and communication is critical. So if you're not expressing what you're feeling and you feel intimidated or scared to speak up, that's going to impede your healthcare. So I say, don't look at the doctor like he's the person that knows it all. That person is there to help you. And physicians do want to help. Nobody wants to dismiss your pain. But if they can't figure out what's happening, they'll say to you, try this and come back and see me, because we're trying to figure out what's going on. And then that's where the delay happens. Let's try this, let's try that. And because there's no clear cut answer until there's a diagnosis, we're going to keep trying things. And that's part of the process. It's not that it's wrong, but that's the best way to do it. So the more clear you are, the more quick you are to get to your concerns, the better results you're going to get. The shorter that time gap, the shorter the let's try things out. And so I think that's really important. So as a mom of a teenage daughter that has issues, If the daughter is not very good at tracking things, then I would ask the questions. Oh, did you have are you on your period? Yes, mom, I'm in so much pain. Oh, what kind of pain do you have? Oh my God, it's so bad. Okay, just write down. She's like in her bed, so bad, because you're not going to remember when you have the appointment in a month from now. So writing those things down really is going to make a good impact because there's 15 minutes to discuss it. So it's not that there is all this time to research things and to figure things out for that particular person. It's you being very responsible in providing the information in a clear, concise manner. And that's going to help you. It's not anyone's responsibility, but in the sense your own. That physician is there to help your concerns. There's a difference. If the physician dismisses even after all of that, then you have to escalate. And my opinion on escalation is if you are not seen and heard, despite having clear, concise information, that's when you want to ask to see a specialist. That's when you want to go see someone else who is going to listen, because then that's a different situation. That's a different type of relationship that you don't want to be in. You want to be in a relationship where someone is listening to you, helping you with your concerns. Don't expect things to be figured out in that 15 minutes. There might be more follow up. That is part of the journey, but keep tracking, keep working at it, and keep advocating. Because if you do that, you will get to the answer. You will. Absolutely, you will, because you're going to keep pushing for the answers. And that's the critical thing.
And I guess what feeling seen and heard it's going to feel different for every person. So you need to understand what that looks like for you, and almost like what do I want to get out of this appointment
Mhm.
before I go? So I have all of this clear information in order for me to feel seen and heard. What kind of progression am I going to be happy with for this consult to take? Do I want a referral to here? How do I want to feel when I walk out of there? So you almost want to have an understanding around what you want out of that appointment before you even go. Mm. So if we move forward into kind of reproductive years, there's certainly some contraception and systemic inequalities, which I'd like to touch on now. So when it comes to contraceptive recommendations, they definitely shift from adolescence all the way through to perimenopause. So what barriers almost prevent tailored care for women at the different life stages?
It gets a little complex because depending on what the goal is. So that's the critical sort of piece in the puzzle. What is the goal? Is the goal to have a baby in a year? Is the goal to, I'm in a long term relationship right now, so I would like to have contraception because I don't want to have a baby. And so this is my number one priority. I want to make sure that I'm protected in that manner. So I want to be on something that I can take every day, or I want to have an IUD where I don't have to worry about it. Moms, after they have babies, I'm breastfeeding. I don't want to deal with a birth control pill. I just want to be able to have something so I don't get pregnant in the next year or so. It depends. It becomes tailored to the person's goal in the contraception. So, keeping in mind that STDs, from the minute you begin to engage in any sexual activity all the way through, contraception does not protect that. When we talk about birth control pills or an implant or an IUD, the only barrier would be using a condom to protect against an STD, which is an important piece of sexual activity. You have to be able to protect yourself against STDs. There's the HPV vaccine that we recommend. There's also the condom that we recommend, and just understanding your partners and that kind of whole non-drug measures to preventing STDs. So it's really important that we factor that in. But when we talk about contraception at the stage, how do we pick which one is best for you? It depends on various factors. Does the person have obesity to worry about? Have they had breast cancer in the family before? Breast cancer themselves? Are they smoking? Because smoking can increase the risk of stroke. Do they have any heart conditions, hypertension, diabetes? What is their other health conditions look like? And what is their other lifestyle factors look like? So that determines as well where you want to go as far as at what point do you want to use an IUD, or are you going to use a Depo-Provera shot where it's once every 3 months because you're traveling and you're not going to remember, or you're going to go away for 6 months and you don't know if you're going to be able to get the same formulation of birth control pill and you don't want to take 6 months worth. There's so many different factors that go into choosing what's best for you. And I think that is also a critical piece in the education, what you need to know about that. And then when you are started on something, it doesn't mean that it's just going to be perfect and it works. That might not happen. If we use an estrogen, you might have increase in depression or increase in suicidal thoughts or increased anxiety. You got to go back and see the doctor and say, these things are not working for me. I got to try something else. So oftentimes we'll see people start on a birth control pill, change it to another one, or then change it to an IUD or change it to an implant. So it's not simple. It's not black and white and it's not a straight line, and it requires patience, and it's just tracking and keep going back and understanding what the side effects are and knowing things that can go wrong as well with the birth control pills, understanding what the side effects are and knowing the risk versus benefit. That's the entire gamut of it. Really, you have to do your due diligence and look up things and understand what is it that you're being put on, how does that affect your day to day. Be honest about things. Yes, I do smoke. Don't say you don't smoke if you do, because that impacts the type of birth control pill you should be on and how and at what age you should come off of it because of the estrogen. So it's really important that you're also truthful when you're explaining your lifestyle and also your other medications that you're taking.
And so, what kind of barriers would prevent women having, in terms of their contraceptive journey, what kind of barriers would prevent them having tailored care at the different stages?
I think what's really important for us to know as women is just because potentially a physician or even a specialist doesn't know us, that doesn't mean that we should just accept what we're being told. Okay, I think that's number one, really important. Most times women will, I don't know the right way to explain this. We're taught to be polite. And so we don't necessarily advocate in a way where we speak up and say, I'm not comfortable with that. So it's really important that if you have that thing inside you, that gut feeling where it's, I'm not going to do this, and you're not going to do it, and you're sitting in the doctor's office and you say, I think this birth control pill is going to be the best, but you're not going to actually go and do it. Just say, I don't feel comfortable with that. Is there another alternative? That's it. Don't have to feel bad about it. It is your body. It is your life. It's going to be how it impacts you. If you're not comfortable with the treatment plan, you have to stipulate that and say that and just say, is there any other options? I'm just not comfortable with that. And then get the doctor to explain to you the risk versus the benefit so that you can understand it and make a good informed decision. I think the barrier is some ways it's us not speaking up. It's us not explaining ourselves that we potentially do and don't want X, Y, and Z. And I think that's really important. I think we need to give ourselves the grace to speak up and to be told that, yes, yeah, you have a suggestion, you're telling me, you've told me what, and I've heard what you've said, but now I'm telling back in a collaborative communication, in a very assertive but not aggressive way. Just say, I'm not comfortable with that. And I think the barriers go away when you have clearer communication.
Now, as women, we have so many different hormones that change throughout our month. We go through different cycles in each month, and each of those cycles have different hormones that impact them. So getting our hormonal contraceptive accurate and right for us is probably a lot more difficult than if we were putting research and funding into men's contraceptive, because they don't have that same hormonal profile that changes week to week and month to month. Why has male contraception research stalled? despite surveys showing, I think, something like 87% of men want options for this. And I have to say, I'm sure the fact that Big Pharma makes like $18 billion annually or something like that from female contraceptives has something to do with it. What are your thoughts on this?
Drug companies are probably the most brilliant companies in the world. And so they will research and produce a product that is going to be used and is going to be, yes, used in a way where it helps, but also in a way where it continues to allow them to function, to make a profit, to satisfy their shareholders, and to continue to do some research. Because it's not, they don't do only bad things. They do a lot of research, and we have had many breakthroughs and many medications that have revolutionized the way we live and allowed us to extend our lives. So there's the good, the bad, and the ugly all in it. But I think what we really, it comes back down to this. And I think this is, in my opinion, why we don't see this progressing. Number one, you're right. I don't think that there's necessarily a huge market for it. Number two, women typically, and I think this is probably why men would like to have more of an option, but women, how many women are just going to trust that the male took the medication so that they don't become pregnant? And I think that's part of it. Women want to know. And so by them taking the medication or by them having the IUD, they have some sense of security that, yes, if anything were to happen, I know I'm okay in the sense, right? I am not going to become pregnant because I've taken measures. And so there's a trust. And I think it flips the other way. Men trust that women are taking their birth control pill every night or whatever that looks like when they engage so that the woman doesn't become pregnant. But I think there's more reliability on the woman doing that sometimes than the opposite. And I think that might impact it as well. I don't know, that's not studied, but I just feel that in conversations that I've had, even just with making sure that the male comes with a condom, sometimes it's the women that I see buying the boxes of condom, making sure that the condom is in fact used, right? So a lot of times it's women who take this responsibility, and I'm not sure that's right, but I see it and I acknowledge that this happened. And I'm wondering and I'm thinking, and I'm basically saying, if you can see that with the condom, I'm sure that when it comes to using other contraception, that women want to take that responsibility. But I do feel that there should be definitely more options for males rather than just a vasectomy. There should be other options because there, as you said, there are other males who potentially want to make sure that they're protected and in the exact same situation. I don't want to rely on a woman that I trust or don't trust to have taken the birth control pill or missed it or taken an antibiotic and now it's less effective. I want to make sure as well. So that could also be in their minds. It does require a push from the male population to demand these things. And then somebody will listen because if there's a demand and there's a way to make income from it, it usually and typically happens.
Yeah, I think even just from conversations that I've had around this, there are scenarios and conversations that I've had where the female might be having a whole host of health issues also relating to her hormones and their hormonal imbalances, there's health issues, and the males, I'm not responsible for this. I don't want to do XYZ. I'm not having a vasectomy. I don't want to use condoms. It's almost like I get angry just hearing this. So there has to be other, I personally believe that there has to be other options out there for women to be like, okay, you don't want this, you don't want that. What about this? Because right now, my body is going through all kinds of changes. I've got all kinds of health issues. I need my hormones to come back into balance. And I've messed up a lot of my hormones because I've been on contraceptive for so long. I actually need you to participate in this discussion and in taking care of my health a little bit by being responsible for our contraception.
Mhm.
And these are the options.
Mhm.
And I personally think that there needs to be more out there around male contraceptive.
And I agree with what you're saying because I think it comes back down to having a really good conversation with your partner at that point, too. because they as well don't know what's happening to your body, and they have no ability to understand the pain that you're going through because they will have never experienced it. I sometimes see those funny memes where they're making a male sit down and trying to see what it looks like for.
Our brains just thought about the same thing at the right.
And they're
Hilarious.
sitting there and they're like in so much pain and they're dying. And it's, yeah, that's only level one
Yeah.
of a contraction. So they don't have a reference point. So I
Mm,
think it's really important. We're talking about women advocating. We're talking about it in the doctor's office. I think you talk about it in the bedroom too, because that
mm.
communication is critical. There isn't enough options. That is 100%. The option is a condom and a vasectomy, and there were some male contraceptions in the past, but they actually created side effects for women as well. So it was like, how is this working? There needs to be more research in this. But I think in the meantime, if there is, women have endometriosis, they have adenomyosis, they have PCOS. There's so many conditions that even just engaging in sexual activity is too painful for them. And it's disappointing that women don't feel that they can have these conversations openly and honestly because they're afraid. And so they'll be in pain through that process, or they'll take medications to help them not be in pain through that process. And that's where, again, it's that situation where life can't be perfect, but I think it's really important to have some of that openness and that communication and say, as a woman, here are the things that I'm going through. I need you as my partner to understand these things and to help me through it. And sometimes I believe that you take your husband or your partner to the doctor's office with you and have them explain, look, she's going through this and this is what I recommend, this is what I think we could do in the future. In the meantime, while she's getting these treatments, I really suggest you use this and this, and bring it in as a couple, as a medical couple issue, because I think that will remove the female feeling like he's not listening to me. I'm trying to explain everything. He's not understanding. The doctor can explain it, and bring him to the doctor's office. You need to come. You need to hear what's happening because I can't explain everything. And so we need to come up with a plan. Let's talk to the doctor. That's how I would do it.
I love that so much. I really do, because it's a joint decision. Obviously it's your body, but it has to be something that everybody understands. That's really good advice. I like that a lot. Now, we're just going to move back to contraceptive choices here, because I understand that contraceptive choices like progesterone only pills can impact later hormonal stages like postpartum recovery and even perimenopause. Can we explore that a little bit with you?
Progesterone only, typically we look at doing that with like a IUD with a low dose progesterone. Sometimes it's to treat things like adenomyosis, where the lining in the uterus is growing into the muscle. And when estrogen is highest, then there's a lot of pain, there's a lot of bleeding. And so sometimes we use contraception as the method to treat some of the difficulties in the reproductive organs of women. So that's where we use these medications. If someone is a smoker and they're around 40 years of age, we use a progesterone only because we can't use the estrogen because of the increased risk in stroke. We can't use the estrogen if there's a history of breast cancer or heart disease or hypertension. So progesterone only, progestin, like, it's used for certain health conditions, and that's the risk versus benefit. So for me and you, if we don't have any of those conditions, we don't want to chance it for later to have an issue. But if I need contraception and this is the best thing for me and I have adenomyosis, I want the progestin. I don't want to bleed. I don't want to have the pain. So for me, that benefit is much better than any risk that can happen with the progestin. So it's not a one size fits all. It depends on the person. But you're right in the sense that the progesterone can sometimes create imbalances, but so can estrogen. And estrogen, we know we with menopause, the estrogen comes down. We have issues with our bones. We have hypertension potentially. There's some weight gain. So there's different things that happen with our bodies as we go through. And each individual person with their other subset of health conditions, with their other lifestyle, things that they do, like smoking per se, if that's something that they're doing, that impacts how we have to treat them, what type of hormone we can give if there's a history of cancer. So that's why it's so tricky. It's not black and white, and it
Mm.
is risk versus benefit. So what could work for you could not be beneficial to me. And that's where it's really important to know this going in, read about it, understand, put in, I have all of these medical conditions. What is the best hormonal contraception for me or a hormonal replacement therapy? Do your research, do your readings, and then go back to the doctor and say, you know what, I read about this, or my mom told me about this, or my friend told me about this. Be part of communities that have discussions about this so that you can get an answer based on your particular situation from the physician when you ask those questions.
And moving into that more perimenopause, menopause conversation, I feel like a lot of women that are in that stage are told that they're almost too old for birth control. Now, you and I both know that you can fall pregnant until your final ovulation. So, why are women being told this?
The rates do decrease. Definitely the way that our bodies work, the ability to hold on to a pregnancy, the progesterone, the estrogen, it does decline. We don't ovulate as much. The eggs are not as, for lack of better words, as young as before. So there could be deformities. And so you sometimes women who are having a period probably don't even realize that it's actually a miscarriage because it's in the first 7 weeks. It's just a late period. We know that lots of women do miscarry and they don't even realize it's just a late period. So as you get older, it declines your ability to get pregnant, but that doesn't mean you can't. I'm again on a personal note had a baby at 45, so I got pregnant when I was 44, and it's not something that can't happen. It can happen, and it does happen. So it's a situation where if you don't want that at all in your life, you do have to still ask for contraception. And as you get older, the estrogen levels sometimes, because of the way that the estrogen in birth control pills is formulated, can create more risk for you. And so you really have to be careful with what you're choosing as your contraception. And you need to have those discussions because it's really important. And especially if you layer in something like if you have adenomyosis or if you have endometriosis or if you have any other medical conditions, it's really important to know what those things are. I think the other piece to this is a lot of women throughout this journey, when they have an issue, I think I've seen and heard many women who have had hysterectomies that wish they wouldn't have, that regret that decision, that wish they would have had more knowledge before they made that decision. And I think that's also a really important piece because then later, when they are going through the change of life, but even though they had a hysterectomy, the bone density, their heart, things change. And so they've had to be on different medications when they've had the hysterectomy potentially. And so understanding the long term effects of what that looks like with medications and how that's going to affect your body is also really important because way back when things weren't going well, or if you had massive amounts of pain, even something like adenomyosis, one of the treatment options is hysterectomy. So, really
Mm.
understanding what that means is important. Women, after they've had 3 or 4 kids, sometimes their contraception is tubal ligation. They just get after right after the baby, they have everything stitched up and sewn, and they can't get pregnant anymore. No contraception required after that, but no baby ever after that either, right? Like it's really rare to reverse that. So all of this becomes a personal choice and a journey, but understanding the decision that you're making at the time is really important because it's going to affect the rest of your life.
And when it comes, I'm like, I'm really going down this path, aren't I? But when women's health issues like contraception and menopause, again, they receive less than 1% of funding. Like, how has the gender gap in research shaped the quality of care across women's hormonal journeys? Because it has to have.
A long time ago, women lived till they were maybe 60 years old, right? 55,
Mm.
60, and that was considered a really great life. We see women now, the average age is 82. So you talk about going through menopause between 50 and 55, and now you're living another 30 years. There hasn't been enough research for that. And so I think there is a real lack of knowledge that we need to catch up on. We need to retroactively go back. We know that women's hips break. And once that happens, that's it. They can be as active as they were before. They're okay. Now you have toileting issues, can't get to the washroom, their hip is hurting them, their activity levels go down. It's just a decline, right? And so, why is that? And so then we go back and we say, why is the bone density like that? And then we look at it and say, because the hormones affected our bones so badly. Then why haven't we done something about it? So we're starting to now go back and look at those things just because we've aged and we've pushed that age and we see those complications now more. And now we're trying to figure out, how do we fix that? And I think we as women need to, in the healthcare field, in the research fields, push for this more, because we need to have more of this. But there's so many competing factors. There's so many different research things that are happening. It's just, I don't understand exactly when and why someone decides on the research, but I do know that if there is a group of physicians and organizations that push for some of this research and fund it, that's the critical thing, funding the research, then it gets done. And I think corporations need to look at women research, because it is us, the women, who are pushing our ages longer, and we're the caregivers of the world. Women's health and women caregiving for the world is important in all of this world. And we need to respect that, and we need to do something about it. And I really do believe that it's up to us as women to demand it. How many times have you heard a woman say, you know what, I really hope that they do research on this? We need to advocate for that. Join local organizations that do research, or that have government bodies that we write to and say, I'd like to have some more research into menopause. We see that movement right now. Fortunately, that is happening right now. And I think it's because, like I said, women are living longer and we see the complications later now. And now we're going back retroactively and saying, why are these complications happening and how do we fix this? Now, the recommendation is at 20 years of age, we should start taking vitamin D. So when I was 20, nobody told me about vitamin D. I didn't even know it existed. So I think there's progress. Are we there 100%? No, but there's progress. And I think it's up to us as women to push it.
I think it's like a generational thing. So we almost need to inspire younger generations through our own journey. So we need to be having these conversations with younger women so then they understand, listen, XYZ is happening. Whereas I feel like when I was like you in your 20s, we weren't made aware of this stuff. So I think it's up to our older generation to let us know what their troubles were. It's up to us to let the younger generation know what's coming and what they need to do about it. But I'm going to do a little sidestep here because you mentioned a broken hip. Now, I'm going to do a little plug for resistance training because
Mhm.
I train I think she's 70 something now. She's probably my longest client. I've been training her almost since I became a strength coach. And so she's now in her early 70s and she's incredible up until recently when she fractured her hip falling off a horse, I think it was. Now, I've strength trained her for probably 15 years, and she's a weapon. Like some of the stuff that she can do in the gym, I have 30 something year olds that couldn't do what she could do in the gym. Like she was incredible, like such an inspiration. She fell off a horse and fractured her hip. And because she had done all her resistance training and she had that bone mineral density from the resistance training, she's back in the gym now. She's back in the gym and we're 4 or 5 months into her journey. And she's really starting to, all of her muscle memory and her central nervous system, it's all coming back and she's really going ahead in leaps and bounds. So I think it's really important that women do strength train and we do it through our whole lives because of things like this. So I think there are definitely things that we can do through as we age to make ourselves more resilient. And it's interesting when you talk about how we're definitely living longer because something that I see quite a bit. And I certainly know from what I do, I think it's in the top 3 reasons why women end up in care homes is because of their pelvic floor and incontinence.
Mhm.
So this is something that I feel extremely passionate about, in that as women go through their pregnancy, postnatal period, that their pelvic floor is really cared for and they're not being pushed back into exercise too quickly, or they're not lifting too heavy, and that they're really understanding. Don't get me wrong, I'm all for women training hard through pregnancy and their postnatal period, but they really have to have that understanding around their pelvic floor, because we are living longer.
Mhm.
We are living into our 80s, and things that you can do with your pelvic floor during that pregnancy and postnatal period does impact you later in life. So you need to be really caring for it through that time. That's something that I feel passionate about, because it's a message that I see in the fitness industry quite a lot around. I know I'm going off on a bit of a tangent here. I'm sorry about that. But back in the day, women were back in the fields straight after having babies. We can do X, Y, and Z, and you can go back to training. It's like, yeah, but they were also not living until 80 something,
Right.
They were like dying at 60 if they were lucky. So we've got all these extra years that we need to be careful around our health and well-being. So,
No, you're right. What's really important when we look at this, even in fitness, right? Women
mhm.
weren't running marathons. It was bad for their health at one point. The research was, no, we got to take this woman off of she had to run pretending that she had a hoodie. What?
Well,
What?
they weren't allowed to. They weren't
No.
allowed to participate. Isn't that crazy? It
Yeah.
wasn't, I think it was back in the 60s, the first woman that did the New York Marathon or something like that I saw
Yeah.
recently.
So things progress as we look back and say, oh, that wasn't right. We look back and said, oh, you know what? Women shouldn't be lifting heavy weights at the gym. That's not right for them. And now we turn around and know, no, actually, that's the best thing for their bones. This is the best thing for us. So there's progression in what we're understanding. There's more that we can do. But this is where, as a woman, when I talk about education, I talk about it being understand the different things that you can do in your wellness journey so that you can extend a good quality of life. It's one thing to say I live till I'm 82, but what is your quality of life? Are you wheelchair bound? Are you unable to get up? If you fall, can you get back up? Can you sit down on the toilet and get back up without bars? Everybody has a different journey. But if you take some of the wellness and put that into your day to day, just go for a 10-minute walk every day. There's things there that can help later in your life because we are living longer and there is medication to help treat things so that we can live longer. So you're somebody who was diabetic way back when wouldn't live until they were 80. We see diabetes increase, but that's not because there's more people who are diabetic necessarily. It's because people are living longer. And so we see more diabetes as well. And they're treated. And so they can live even longer with the disease. So I think it's really important for women to understand that our hormones dictate who we are, our moods, our anxiety, our instincts, our ability to love our children, to make breast milk, to produce a baby. All of these things are in women's bodies. And we need to set that. When I talk about advocacy, I'm talking about that in our entire lives, not just in a doctor's office, not just in the healthcare system. We need to set a tone for what we want in our life and really put that in place. What is our goal in our life? And we do everything, right? We go to work, we clean the house, we look after the kids, we look after the cats, the dogs, whatever it is, right? So, what is the intention for my life? When I'm 80, what do I want to look back on and be able to do? And if that means, you know what, I'm good, I'm okay with XYZ, then you're going to live your life in that way. But if you say to yourself, I want to still be active, I want to be able to still go and do this, I want to still travel, those things then mean a decision that you make requires those wellness things to be put in place now. And it's the same thing when we look at sunscreen for wrinkles. That happens when you're young. And that doesn't happen when then you're 70 and you say, I want to reduce my age spots. And yes, you can do something then, but it is prevention. And that's what this is about too. So it's a journey throughout your life. And advocating for what you want is really important throughout that. And we need to give women the right to be able to dictate that and to say that instead of we drown. We go to bed at night and some of us drown and we think, oh my goodness, I have so many things to do today. And the guilt, and because we want to be everything to everyone, but we have to be number one. We have to be for ourselves. What is it that we want? Because if you're happy in your outlook and in what you want to do, that's going to make a big difference. And I say this, and I'm trying to explain it in a way where, in a medical sense, in your healthcare, and when you're advocating for your physician, you're going to make sure that those things are looked after because they're important to you, even at that stage. The screenings that you have to go to, all of these things, you're going to find out about them and you're going to follow it and you're going to put it into practice. And I think that's really important. And you're going to ask those questions about risk versus benefit to do what's best for your body.
I totally agree with all of that. Absolutely. But let's talk about clinical trials, because women are actually excluded from, I think, about 70% of clinical trials. And I'm sure this must skew contraceptive safety data and actually leave women vulnerable to their side effects. Can we talk about that a little bit?
I think that's partly it. The way that clinical trials are done is it's a subset of information in order to bring the product to market. So it's not representative of the entire population. So once a medication actually hits the market, that's when we start to see how the drug in practice works. And that's when we start to call it evidence based research. And evidence based means, well, we can see what's happening. And based on what's happening, here's the research that we have. Clinical trials is not evidence based. Clinical trials is a controlled setting. So you have certain population group taking a certain medication. They have either the drug or they have just a sugar pill, and they compare what the side effects look like. Is it actually doing what the medication's supposed to do? Decrease blood pressure? Yes, great. Then what are the side effects of that? Does it affect anything else? That's a clinical trial research. But when it's evidence based and put out into market, that's when we see everything that happens. And that's why it's so important to go back to the physician, to talk about your side effects, to explain what's happening. If there's adverse events, things that, are not even on the side effect profile, that those get reported. That's how we know what is actually happening with the medication. The issue is that the subset of population, when we go through clinical trials, is very limited. The amount of women that go in through clinical trials is reduced, seniors reduced, different subsets of populations, European, Caucasian, different segments of that don't even enter into the spectrum of clinical trials. So then when it's put out into the population, we actually see what's happening. I don't know how that will change because there is a controlled study and they just want to prove that the drug works for what it's going to say, and here are the side effects. They're not necessarily forced to say what's going to happen with a wide audience and a whole bunch of different people, because their objective is, this is a clinical trial and this is what we're trying to prove. It's not what are all the side effects that can happen, how can this affect different people, different women, men, different ethnicities. It's not about that at that stage. So that's the gap that exists.
Have you got any thoughts on why? I feel bad saying this, but have you got any thought about why Big Pharma has prioritized those big blockbuster drugs like Viagra over things such as male contraceptive?
Yes. We talked about it
Would
at
you
the
like
very
to share
beginning.
them? Yeah.
Demand equals supply, and there is definitely demand. There was demand for that, and because there is, that's how it was marketed, and that's where it is today. And it was a revolutionary medication. It started as a medication for high blood pressure. The side effects of it were the other, and so male erection was treated in that way. And now it became this thing. It wasn't necessarily studied as a male erection medication, but it was a high blood pressure medication that had that side effect, and they noticed that, and then they rebranded it and marketed it in that way. So we see that when something is supply versus demand, That's what's going to happen. When we talk about diabetes medications, now we're talking about all of the Ozempic, Mounjaro. This is in high demand. This is what's making the money. Lots of research is being put into that.
Okay. Now, what are your thoughts on a culture of medical gaslighting and why they persist in contraceptive care today? With 56% of women reporting dismissal of symptoms, there has to be something going on there. What are your thoughts around that?
Again, I think it's lack of knowledge. I
Mm.
don't think that there's enough research that then translates to the education system that then translates to actual practice. So when something is not known, it's dismissed. And that's the biggest gap. I also feel that there's this, and I don't know if it's the right way to say it, but women have and tend to have anxiety around things, right? We're anxious when our child is sick. We're anxious when our husband is sick. We're anxious. We're anxious when we're sick. What is this? What's going on? So that level of anxiety is a protective mechanism for us because when we're anxious, we're more alert. And so it happens in our bodies through our hormones, all of it. So I think the medical community looks at it and says, you need to calm down. This isn't as bad as you feel. Their job is to say, let's get down to the basics and the facts and let's see what's happening. And I think that comes across in a lot of times who maybe physicians aren't skilled enough to approach it in a way where it's let's look at how we're going to manage this, because even myself as a healthcare professional, I would have moms worried and say, if she takes this medication, is she going to end up getting this or that, or and it's just, ooh, let's bring it down. Let's talk about the actual side effects that this medication has. Let's look at what you need to know. What are the red flags? What are normal? And then make a decision, right? Because anxiety does take a huge role when it comes to our bodies and our children's and our family. It does. It's you ask any woman, if someone says this might happen, then you're thinking, oh my goodness, is this going to happen? Because that's a natural part of how we react. You have some men who do have anxiety, but mostly you'll see that in women when we're trying to advocate for our children or for ourselves. So I think the anxiety piece is really important. When we are anxious, we need to also take a deep breath and be clear in what we're trying to ask. And that'll help reduce that gaslighting because now it's not about trying to make you calm down in the sense, it's more about listening to your concerns. And that's where we have to advocate in a better way. Asking the right questions, being clear and concise, and removing that anxiety is going to be taking a few deep breaths, reshifting your mindset to, I've got to ask these questions because I just want to know the answers. Yes, I'm scared. Yes, I'm worried. And maybe you just say that I'm scared. I'm worried. I need some reassurance. I need to understand what's happening. I need this from you. And if you don't get that, then, like I said, you have to escalate. Is there a reason why you're not doing that test? Is there a reason why you're not looking into these symptoms? Is there a reason why this is happening? And that's how you continue the conversation and the advocacy for yourself so that you don't get gaslighted and you don't get dismissed. Because it's very easy when you're rushing and you don't have a lot of time and someone is just, let's just say, very anxious and you can see that anxiety to just say, you need to just be, you're going to be okay. Take this medication, come back in a week.
And so, how can people use your ACE framework? Firstly, let's explain your ACE framework. And then, secondly, can we talk about how a woman can use your ACE framework to almost transform her contraceptive journey through the healthcare system?
Well, the ACE framework really came out of my own advocating. I had to advocate for myself. I had to advocate for some of my family members, for my children. So I learned that right away, ACE is based on advocate, communicate, and educate. And the advocate piece is removing any barrier that you have to speak up. Just take it away because you're going to have deep rooted thoughts about the medical system and its healthcare, and somebody knows more than me and I shouldn't be questioning, and I how dare I ask that. You have to remove that barrier has to be removed. You have to shift it to, we are in a collaborative approach. I know my body. When I explain things to you, you can help me solve my problem. It's collaboration. So that's the advocate piece of A. The second part is communicate. Communicate clear, concise, know what to track, how to track it, and how to record things. And then the educate piece is doing your research from credible sources and making sure that you know the treatment plan, you agree with the treatment plan, and you follow up on the treatment plan. So if it's come back in a week and let me know how you're doing, track how you're doing in the week and go back. Don't, oh, you know what, this isn't working. I'm just not going to go back. No, go back. Keep going through the journey. And so those three key pieces in any healthcare situation, but especially when it comes to contraception, because it is a lifelong journey. It's not just one thing and done, it's lifelong as our bodies change. You want to keep using those three key principles. Speak up, be assertive. I wouldn't say aggressive because that just shuts down anyone. So be aggressive is not the right way to do things. Be assertive, talk like you're just stating matter of fact. I would like to know, I would like to understand, I would like to know the risk versus benefit. Ask your questions, write them down, bring 3 into every appointment, talk about your signs and symptoms, talk about what you have to record, what should I do to come back, how do I make sure that this medication's working or this surgery, tell me the risk versus benefit. And then when you're doing that and going through that process, make sure that you educate yourself on what that treatment plan is and how it's going to affect your life long term, because there is that information at our fingertips now.
That's amazing. And before we sign off, just one last question. What's the one thing you wish all women knew before having a baby?
I think this one for me personally is that it will transform your life, but you need to be as healthy as you can before that happens. You need to make sure that you reduce your caffeine, you get the right vaccinations before you become pregnant. You make the journey something where it's a choice that you want, and hopefully that is how it works for you, that you can plan it and it is a choice. And whether it's planned or not planned, the joy on the other end of that is that you will be connected with someone the rest of your life, and that experience is lifelong and it is treasured. And I think it's one of the great things as women that we do have is the ability to bond with our children genetically, emotionally, and physically, in the sense of they're grown within us and we feed them and we hold them and we are their main source of comfort and throughout that journey. And I think we protect them as well. So I think as a mom, letting go of any guilt and what the perfect way is. There is no perfect way. Just have a heart full of love and it's always going to work out.
Beautiful. Thank you so much for your time today. I know that conversation went all over the place and we delved into maybe some political realms there, maybe, let's say. So I really appreciate your perspective on all of that. And thank you so much for your time.
Thank you. I appreciate it very much.
And if you're hearing this message, I want to say a huge thank you because it means that you've listened to this entire episode. Of course, if you have any questions about the things that we covered in this episode or want to know more about me or my other projects, you can find me on YouTube and Instagram at The Pregnancy Process.